Can you guys hear us?
Yes.
Okay. We were on mute in a weird place in the room. We were actually going with the meeting, and then realized that y'all couldn't hear. So we will start over. Take from the top.
Take it from the top. And it was we did a good job the first time.
We did do a good job. Y'all missed it.
Again, I hope everybody had a great holidays, and thank you for tuning in today. Our main topic today is going to be fee for service. And we got a group here that will answer all your questions, or we will run it down afterwards and get the information to you. We're going to go over each topic. Please, if you have questions, type them in, and we will pick them up as we walk through them. And if we don't get them done today, we will follow up with you individually. The first one is just a general category of fee-for-service contracts that we have started to roll out, and I want to turn it over to Lori to talk about that process.
Sure. Before I do that, I wanted to go around and let you guys know who's in the room because it doesn't look like we have video.
Oh, okay.
Y'all can't see us, right?
No.
No, we
Okay,
can't.
see us. Okay, so Lori Manus, I'm in here. Pat, obviously.
Joe Fry.
Panzeruto.
Rufus Brett.
Deborah Leopard. Carol Mitchell.
Okay.
All right.
I just wanted y'all to know who was in here. So the first item on the agenda is around fee for service contracts. I wanted to let you guys know that the contracts went out to everybody last week. I think on Thursday, they came from Deborah Leopard through DocuSign. Those are contracts that DDSN worked with HHS on to kind of include the language that you guys would be direct billing services for Medicaid waiver participants. But the contract intends to cover both waiver and state funded for the services that are listed in the Appendix A. So for each provider agency, your Appendix A outlines the services that you are qualified to provide. We need you guys to get those contracts signed and returned so that we can sign and execute them. You will need them in order to apply for provider enrollment through HHS. They're going to actually ask you to upload a copy of that contract, so that's kind of the hurry on that. We have had a couple of questions about it. So for those questions or comments, if you want to just send emails, we will definitely take a look at those. But again, like I said, those contracts are a joint venture between us and HHS. So we really can't, we really can't like make any changes without their input. So. Okay, the contract we got without any money or tiers attached, and it says it starts 3/1/21. We cannot sign unless I know what our outlier rates will be. So the information posted includes procedure codes only, and that was purposely. There is documentation of what those procedure codes equate to in the form of rates. The reason that we didn't put rates in the contract is because we don't want to have to amend the contract anytime Medicaid changes rates, since they're Medicaid services. For state-funded services, we will apply the same tiers and rates to state-funded people. So.
Also a predicate for the enrollment process. So you really do need to sign those contracts and get them back as soon as possible.
Right.
About 40% that we've sent back.
Oh, okay. We've already gotten about 40% of them in and executed. That's great.
We sign them and then we get them.
Again, like I said, if you have general comments about the contract or you see anything, I think we've had a couple people ask a couple questions about why things are the way they are. You can send them in. We'll be glad to take a look at them. Nope.
All right, we'll go to the second topic, which will be direct billing training. We had enrollment training in December, and we thank everybody for participating. And if you have any issues with that training or have not gone to that training, please give us a call, and we'll take care of whatever it takes to get you enrolled. The next phase is going to kick in this month. It's going to be direct billing training. So I will turn that over to Lori.
Sure. We had another question about contracts and whether they reference the approved leave days. They do not include the leave days. The leave days will be part of the policy around residential services. So those will show up in the standards or other policies that we have. We're still working with Medicaid about where exactly it goes. But Medicaid did announce this morning at the HSP meeting that the leave days will be 20%. So that's 73 days a year. So for the training, again, like Pat said, you guys have had the provider enrollment training. They did tape the last training that happened. I think it was on the 22nd or something like that, or the 21st, but they did tape it. They do have the PowerPoint. HHS is working on a microsite. It'll be part of their website where they will house all materials, including that training session, as well as the PowerPoint for that training session. And they have an FAQ document that they're keeping up to date based on the questions that you guys are sending to that email account. So all of that will be included on that site. Did she? I don't think she said today when it'll be up, but I think they're trying to get it going as quickly as they can. Once you get through provider enrollment, which at this point, they have not opened the provider enrollment portal for you guys to apply. They will provide notice to you when that is available, when you can apply. So my understanding is that once provider enrollment happens, they are going to push a couple of providers through, and they will use those two providers to do testing related to billing. Then they're going to schedule the training on billing behind the testing. The whole idea there is they want to learn something from the testing before they do the training. But I would look for those training dates to come out within the next, few weeks. And there will be webinars. Those trainings will include how to bill manually using, what's the number of the form, Carol? No, the manual, the paper form. They're going to do how to,
1,500.
the HCFA 1500 paper form. It'll include training on how to use the web portal, and it'll also include training about EDI transfers, which is basically what it would be if you guys use their app to do your claim processing. Somebody said that Margaret said the training video would be up by tomorrow. That's great. I didn't hear the date, so that will be up pretty quickly. And provider enrollment is where we apply for our Medicaid provider number. That's correct, but you cannot do it yet. It's not live yet. So when you went to the training, they showed you like what kind of provider that you're applying to be. That's not an option yet in provider enrollment. So. The 5-year provider renewal application was supposed to be open 1/1/22 and is due 1/31/22. When will that be open?
MMO.
Are you talking about the fixed price bid on MMO? Right, so, okay. So the fixed price bid with MMO is going to change pretty significantly as part of this transition to direct billing. Because for the services that are in the waiver service contract, which is any residential day or waiver case management, all of that is going to be done through a qualification process that won't be through a fixed price bid with MMO. There will be a small fixed price bid with MMO for services like early intervention, Medicaid targeted case management, and intake, right? So, it initially expired, it was going to expire 1/1, but we had it extended through 1/31. So we're working on that new fixed price bid and hope to have it to MMO pretty quickly. All right, when do we have to make a decision as to how we bill? Meaning how our agency bills HHS through the Medicaid portal manually or through their app. So, That's kind of a tricky question because the truth is, when you're a Medicaid provider, you can bill however you want, whenever you want, right? So there's not really this whole decision date about, I got to decide I'm doing it this way or that way. That being said, when TheraApp has a billing module available, I am certain that they're going to need to know who is going to use it and who is not going to use it, right? So at this point, I don't have a date that you have to know by, but it's just something to be, thinking about. I'll roll into the TheraApp direct billing module. So we are working with TheraApp daily, pretty much, to try to get an option available through TheraApp for you guys to use for billing ahead of the 3/1/22 go live date. That's absolutely not something that we can guarantee at this point, but we are hopeful that TheraApp is going to be able to do it. Once we get to a point of pretty much assurance that they're going to be ready to go on 3/1, I imagine that they will have trainings available simultaneously with the Medicaid folks around how to bill. So that's kind of how it will work. So Jason Towner says, for state-funded services, the adult day health, does the local board have to pay and then get reimbursed, or can the provider of the service directly bill? So for state-funded services,
And TDSN doesn't authorize adult day health. We don't have any state funding.
we do in community, in state-funded community supports.
Adult day health, yeah.
Should just bill us directly.
So I thought they do for most things. What do they not bill us for in state-funded community support?
Adult day health is a direct bill service.
No, I'm talking about state-funded.
Right. What I'm saying, as a program, they can bill Medicaid directly, and they do it now.
Right.
So currently, they are having to bill us for state-funded services. For adult day health state funded, they bill us.
So Jason, I think I understand your question. Let me look into that and we'll let you know, okay? There are some weird things with state-funded community supports, and it has to do with vendor agreements and stuff, but I will do what I can to do what I think you're asking me to do, right? I need to look at it and see if it's something we can do. Jerry says, what are the taxonomies that we need to add into the DHHS application? DHHS can't give us that information. What would be helpful us to know which ones we need to focus on? So I don't know anything about taxonomies, and I know HHS is really hesitant to tell people what taxonomies to use. So I think that's really a question for them, right?
For the DDSN folks, the taxonomy would be intellectual disabilities. That's what taxonomies are, right?
Well, they're like groups of services, right?
Right. So.
But they're not.
DDSN taxonomy is intellectual disabilities. So it's not a wide ranging kind of deal.
We'll ask.
Right.
Make sure it's added to the FAQ.
Well, I think it was addressed in the second provider enrollment meeting. Jerry, I don't know if you attended that. So if you didn't, you might want to watch the video, because they talked more about taxonomies in that second training than they did the first, because they realized there were a lot of questions. But I agree with you. I heard them say specifically, we can't really tell you what to use. We can only tell you kind of what they are. So, I'm hesitant to do that myself. So when will we be trained on how to bill through TheraApp? That will be TheraApp doing the training in order to let people know prior to their decision to use them to bill, right? So it'll probably happen sometime in late January, early February. This seems like a lot of up in the air processes to be worked out in 2 months. Is the 3/1/22 go live date set in stone? And if not, when would that decision be made? HHS has said that there's a 3/1/22 go live date. So I think that's gonna be a go. Will the provider be responsible for the cost of using the TheraP Direct Bill module? So Susan, at this point, our current contract with TheraP includes that module at no additional cost. So providers would not have to pay anything to use it, you know, during this year extension. Now, the entire electronic healthcare system record RFP will be rewritten at the end of the year. TheraP may be the provider at that point. It may be another vendor that's the provider at that point. But I think as long as we have TheraP, that's kind of included as part of their software. So it wouldn't cost anything additional for the provider. To clarify, the enrollment is not open at the moment. My understanding from this morning's meetings with the HSP is that Margaret said it's not yet available for them to enroll. Somebody's offering to help taxonomy code. No more information about clarification for adult day health care. Just trying to read. HHS is going to consider a 7/1/22 go live date to assist with the simplification of cost reporting. Have we heard anything back on this? I'm not aware that HHS was gonna consider. Huh?
They mentioned it at one of our meetings,
Oh, did they?
Well, this morning,
Jeff was questioning.
questioning
Yeah, this morning, Margaret said 3/1/22, so
Right.
I think that's where we're going. Need clarification on day employment services currently included in the WGH rate. What's the WGH rate? My understanding is going forward is not a WGH provider responsibility. Currently, we pay the provider as of what date do we instruct day employment providers to start billing Medicaid directly? So maybe what this question is about the bundled rates and you guys getting a bundled rate and then you pay for day and employment out of that bundled rate. That goes away on 3/1/22 when everybody's direct billing. Another question about the recorded training. My understanding is that Margaret said it'll be available tomorrow. I know they're building a microsite. It likely will be somewhere on the HHS website. We'll make sure they send something out. Any other questions? All right, Pat.
All right. Number 4 is that the pending fiscal impact issues with the IDRD waiver. There's 2 remaining. One is the, actually it's really the cost report updates plus the waiver. The first one is the ICF community rate increase. On December 29th, just before the New Year's, HHS sent out a communication from Robbie Kerr. Of course, Jeff Saxon did it, and I can't give Jeff Saxon enough credit for all the work he's done in the last 6 months. He's really just done a ton of work, and he promised to get us the waiver case management rate and the community ICF rate before January 1st, and I think he's right on the money. But on 12/29, a communication came out that said that they are going to increase the ICF rates by 6.27%. The only distinction is we have to wait. We're waiting for Margaret. Margaret, if you have any information, feel free to jump in. What that says is that both the regional centers at the institutional level and the community ICFs, the way HHS looks at them is they look at them as one cost settled cost, I guess a cost, they cost them together. And so the aggregate increase is going to go up 6.27%. What we don't have from HHS yet is what is the itemized rate increase for ICF community? Currently, it's in the 290s. And what is the itemized rate increase for the regional centers? And that's like in the 457 range. So as soon as we get that actual calculation, we'll pass it on to you. But what they have released to the public is the composite rate between these two services is going up 6.27%. So stand by for the exact rate, and I think it'll be coming out shortly. And the second issue is the leave day policy. I just want to reiterate that. Margaret and Jeff gave us a good briefing this morning at the Human Service Providers, and Lori touched on it. In short, nothing changes. Our current residential leave day policy is 20%, and 20% is very, very, very liberal by national standards. It's generally 5%. And what that means is an individual can have leave days to include personal leave days as well as medical leave, totaling 73 days a year. We did a lot of work on that analytically, and what we found was during fiscal year 2019, the full year prior to COVID, the average leave days per person was about 4.2%. So even though we have a 20% latitude, a lot of our individuals we care for, they have no need for this type of leave. And so when we say 20%, we don't expect everybody to take 20%. That's just the outside parameter that gives everybody great flexibility. But the average was 4.2% in the ordinary course of business. During COVID, it was 2.8%, which is to be expected because of the lockdowns and the visitation issues. And what Jeff said this morning, and I'm just quoting Jeff because I don't have the numbers in front of me, that this leave day policy has about a positive $13 million impact across the system. And how that gets implicated, how it gets initiated, I think we have a little more detail to come. But I would just say from doing the fiscal impacts that Jeff sent out, when we look, your main fiscal impact is using fiscal year 21 data. And so that a provider that had very little leave days in its portfolio homes, they generally were, they had positive increases, 18, 20%. The people who did probably the least well were those during fiscal year 21 that had high leave days, such as there was one provider that had 5.7% average. And again, there's nothing wrong with that provider doing it. They were well within their 20% window. But that 5.7%, when we did the fiscal impact, we took the billable units because at the time of the fiscal impact, the direction we got from HHS was, the policy was, there will be no billings for leave days that is in the rate. And I think having changed that policy is phenomenal. I think that is such a blessing for the system. But what will happen is if you have, and we have some data here, and I'll coordinate through Margaret getting it to you, but we have every provider's leave day percentage for 21 and 19. And if we can disseminate that will give you some idea as to if you had a low, what you felt to be a low net revenue benefit, it could very well have been that you just had a very large leave day percentage for that year. And what that essentially is for the provider that had the highest leave day percentage of 5.7%, under the new policy that Margaret and Jeff rolled out this morning, that will be 5.7% will be all billable days. And that'll be essentially a 5.7, not a full 5.7% increase, but it will be certainly north of 5%. That's very advantageous for the system. And we hope to get you that data so that you can see how that impacted your fiscal impact. And with that said, that covers topic 4. Any questions?
No, a lot of thank yous related to the leave policy, and HHS really listened. Right, they really listened and heard, and we were able to give them a good bit of data. So I'm happy that that you guys understand that's a pretty generous leave policy. So, we're really excited about that. The next thing is, on the related topic of day attendance, is the Appendix K going to be extended? For those of us having to close day programs due to COVID, we are worried about having RIF staff. So the Appendix K is currently in place. The way it reads is for no more than 6 months past the last day of the public health emergency. And the way that it will likely work is that the Appendix K will be rolled up during those 6 months, right? It's not like it's going to end tomorrow and everything that's in the Appendix K stops tomorrow. Once the public health emergency is, declared over, at that point, there'll be some planning and coordination between us and HHS to roll those services back up, because there's a lot of stuff in the Appendix K. So the answer to that is the Appendix K is still going for some time until, we hit that end of the public health emergency. And I think that is the point that we can start talking about timeframes for rolling up services. When we bill Medicaid directly, how is that going to allow leave days for us to bill when they are paying out of services hospitals in the same day? So Medicaid says that they can pay a leave day and a hospital day on the same day for the same person. They do it for other programs and they don't feel like it'll be an issue. Somebody's asking about where to retrieve this recording, because everybody wasn't invited to the call. So maybe we can figure out from Christy where this recording ends up. I don't know.
Okay, we'll send it out to you.
Yeah, that's it.
Number 5, assignment of new residential tiers.
Do you want me to do
You
that?
gotta do it. What do you mean, do you want me to do it?
So over the weekend, CDSS, okay. Everybody has been migrated to the new tiers based on the spreadsheet that's always been kept in contracts by Deborah Leffert, right? So we kind of took the spreadsheet that she keeps with funding bands and everybody was migrated into the new tiers. That information was migrated into CDSS over the weekend. So at this point, any of you can look at CDSS for any person that you serve residentially and see what the current residential tier is under history, funding band / residential tier, right? So it'll have kind of the new tier available there. The other thing that we are going to do is, hopefully by the end of the week, we're going to send each provider agency a list of your people and what tier they've been migrated to. So are we going to send that through DocuSign? Is that what we decided?
Yeah, PDF through Docs.
We're going to send you guys a PDF through DocuSign so that you will have that information. When you get it, if you have questions about where people are within the tiers, or if you have concerns related to how the migration occurred, then if you guys can send us.
I think what we're going to do is, once we send it out and you look at it, we're going to set up time to talk to you.
Okay.
And we'll send out some criteria for you to collect some data so that when we actually talk, that there's reasonable data in front of us. And I think I'd just like to add is, the outliers generally ended up in tier 3. And some outliers are small and the new tier 3 rate is higher than your outliers. Some of your old outliers are greater than the tier 3
Right.
rate. We know in tier 3, some of those tier 3 could be tier 4, but that's not an outlier. We want to have a discussion to see if the people who fit that mold, that their needs could be better served by tier 4. But for us to have good conversations, we got to set out the criteria, and the primary criteria is staffing.
Right.
Tier 3 is 40 hours a day in the house. Now you may get all 40 hours, but when you bring your contribution to the house, that's a lot more staffing to the house. So we generally have to look at the house staffing patterns to see if your tier 3 needs to be a tier 4. And conversely, some people in tier 4 used to get a higher rate. They may think that there's something wrong with that. Okay, in order to get that, in order to have that discussion, it's all going to revolve around your existing staffing in those homes.
Right.
To see if you're some true anomaly. And there are true anomalies out there, but generally speaking, they're going to be handled within the tiers. And if there is a true anomaly, and there we have them, they are called
Single case agreements.
single case agreements. That does exist, but they are going to be, they are the by far the exception, and not the rule. So so we'll give you data, we'll give you some criteria, then we'll have a discussion.
Sure.
So that everybody can feel like each person is jiggled into the right tier, primarily 3 and 4 are what we're talking about.
Yeah, so we'll get you those lists out as soon as possible, but if you're curious about a specific person, you can look at them in CDSS. It's out there, happened over the weekend. Those of you with case management probably realize that because case managers are kind of squirming a little bit because there was some migration that happened over the weekend in their app, where the new services are going to have to be authorized. The other thing is there's going to be another migration to get you guys new authorizations for all the new tiers. I don't have the date for that yet, but it's going to happen within the next couple of weeks. So just kind of be on the lookout for that. What will happen is all of your current Res Hab authorizations will end and you will get new authorizations at the new tiers. There's a question about whether the Appendix K is going to be amended to allow to bill day services at alternate locations when it's not safe to have the day program open. So that's already available through the Appendix K right now. For residential, right? That's all I got.
Next topic is 10% FMAP. We have no update from HHS. I think they have everything they need. They sent everything off. We're waiting for them. And I would caveat that it's not final till it's over, but I think the vast majority of what we had in our original budget went unchallenged. They did challenge one item that we'll wait till it's over before we talk about, but keep on saying it's going to be close, but I have to believe it's going to be close because 10% FMAP ends on March 31st. So I think we are at some point going to be in a position to get approval to pull that trigger. 6.2% FMAP. I'm going to turn this conversation over to Director Fry so she can describe what we're talking about here. And I think this is very positive, but we're still in the formulation stages. So
yeah, so we discussed this morning with the HSP meeting, but we are in the process of having a special meeting arranged with the commission in which we have presented a recommendation about use of the 6.2%. We're optimistic that that meeting will happen either Thursday or Friday, but we are awaiting to make sure that we are able to get a sufficient number of commissioners available for that time frame. When we get that solidified, we will communicate and of course and post the meeting details. We obviously have to do it 48 hours in advance. So to be determined, however, there will be a meeting hopefully this week. We know that there will be a meeting about utilizing those dollars to help the network address some of the labor crisis that everyone is confronted with.
that would be in addition to the 10%, whatever's coming.
Yes, so
Not
that's separate and in addition to the 10% FMAP.
All right, room and board, I'll turn that over to Debbie Buzz-Rudy.
So far, all of the room and boards have been touched and worked on, and there are about I'd say about 35% we have approved. We're waiting for responses back on some of the questions that we have, some of the data that we need in which to complete. A lot of people weren't in last week, I think, and the week before. And so hopefully, as soon as we get the data back that we need, we can push this off and say that we're done.
Nope.
And as most of you know, I am retiring. Today's my last day, and I want to thank everybody for their help and assistance over the last 5 years. It's been an honor and a privilege to serve, and I really think that fee for service is going to help in a lot of ways to simplify the way we serve our people and get providers a more healthier revenue stream once we get through down the shakedown cruise over the next couple of months. So we ask for a little bit more patience, and I am sure we will get through it. But in the meantime, Debbie Punzer is going to be the interim CFO. I believe the posting for the CFO position closed today or yesterday, and so we'll be on with that selection process, and everybody's replaceable, but it's been a pleasure, and I thank you for your help over the years. Any other questions out there?
No, everybody's wishing you luck.
It's bittersweet.
We're trying to act like he's not leaving. Yeah. Bruce and I are boycotting.
All right. Anything for good of the order?
Contact information for Debbie, we can send that out.
I'll put you on speed dial at Pat's house.
Yeah.
All right, well, thanks, everybody. We appreciate it, and we will see you soon. All right,
Thanks.
bye-bye.
Okay. Hold on.
That's what I thought he was saying, yeah.
That's how I understood it, that HHS agreed to that. But, I mean,
That would be. I was thinking,
for residential,
yeah. That's what, 6 days a month?
73 days, he said, total for the year. And whipped cream for lunch?
No.
Okay.
I don't know who that is. And I can't find, I even tried looking by the social security number. There's not another form.
No, okay, do, change your status to all up there, above, yeah, right there. And
Oh, so you
now,
think it might be like an inactive?
it might be, 247. Let me try that again.
Do I have to actually type it in?
I think so.
I mean, wait, it's still, I hit results already, so it should be pulling up.
But you didn't have anything in there, right?
No, I left it at 0. I left it nothing in.
Oh,
in
you're
it.
trying to pull up everybody, I got you.
Yeah,
Well,
because then it's,
just type in his social.
oh, I see now.
Oh,
Oh,
okay.
it's on there. Is there any?
Down here, you
I
can,
thought I just. It's just still trying to turn the page.
oh, yeah.
I guess because before I had tried to, and it didn't bring anything up, but maybe it's because it was under active.
Yeah, because there may be some terminated people in here.
Yeah, Billy Bland.
Billy Bland. Yeah, I think he.
That was a termination.
Yeah, he's right here. You want to staple that to the back? Yeah, I got his open enrollment thing. Staple that.
Rest of it. They're not stapled. I know some of them have multiple pages. I didn't staple, although there are some people that were stapled.
Yeah, I mean, you can staple if you want. Okay. So, I am thinking